Okay, let's get started. Thanks so much for joining us this evening. I'm joined tonight by Dr. Jason Bussa, the Associate Director of the Michael G. DeGroot Center for Medicinal Cannabis Research, and Mr. Alan Fine, our Lead Research Coordinator. It is our pleasure to welcome you to this pre-conference session. Our main meeting does start tomorrow morning, but this is the first of our fundamentals, or first of our foundation sessions, which are intended to provide a foundation for your knowledge when it comes to cannabis research and clinical evidence, and hopefully provide you with a basis for understanding many of the innovations we'll talk about over the course of the conference. I do want to say that we're happy to answer questions at the end of this presentation. You can put them in the chat and we will try to follow them, but it's ideal if you use the Q&A button just so that we are able to keep better track of the questions. And with no further ado, let's get started. So I do want to start with some disclosures. I do receive unrestricted research funding from a variety of philanthropic and federal sources. I am a principal in a startup company called Beam Diagnostics and a consultant to a company called Clairvoyant Therapeutics. I don't have any consultancies to or any ownership in any kind of commercial cannabis entities. And I want to be clear that the DeGroot Center for Medicinal Cannabis Research has all of its central operations funded by a philanthropic gift to the DeGroot Initiative for Innovation in Healthcare. This conference that you're attending is entirely funded by that philanthropic gift and is entirely independent of any kind of industry funding. So the other thing I want to start with is just a framework for understanding our perspective on cannabis and medical cannabis in particular. And I think that this is best encapsulated in our vision, which is really fundamentally an evidence-based understanding of medical cannabis, including both its potential benefits, its therapeutic effects, and its potential associated risks. And really what this means is we are not an advocacy group for cannabis, and we are not necessarily against cannabis. We're neither pro-cannabis nor anti-cannabis. Our goal as a research center is to promote an evidence-based perspective. And our mission in doing that is really threefold: to apply the highest standards of research methodology to understanding cannabis, and to do this by synthesizing the existing literature, the scientific body of knowledge on medical cannabis, to create a network of cannabis scientists and clinicians here at McMaster University and at St. Joseph's Healthcare Hamilton, our partner hospital. And finally, at the heart of our center is to conduct innovative research on cannabis to advance new knowledge and ultimately contribute to the evidence base on, again, the benefits and harms associated with cannabis use. The kind of lens we view cannabis through, and medical cannabis in particular, is the yin and the yang of benefits versus harms. It's not as simple as black and white. Does it work? Is it harmful? So much as we're interested in characterizing the therapeutic efficacy of cannabis, that is, its on-target benefits for certain conditions, and we're interested in characterizing its potential risks, its off-target harms, and really thinking about the cost-benefit ratio when it comes to cannabis for a variety of different conditions. And this kind of balance, this through line of pros and cons, is throughout our research, as you'll hear over the course of the conference, and will be very much a part of these foundations sessions. So for this first session, there are basically 5 objectives in terms of introducing you to cannabis and cannabinoids. The first is we're going to talk a bit about some basic cannabis pharmacology. what are we talking about when we talk about endocannabinoids, plant cannabinoids, pharmaceutical cannabinoids, etc. After that, we're going to talk a bit about the context for cannabis use in Canada. We're going to talk broadly about the epidemiology of cannabis use and cannabis misuse. Then we're going to zero in on certain population subgroups who may either differentially benefit more or be differentially harmed more by either recreational or medical cannabis use. And then the last thing I'll touch on is a brief primer on how to evaluate the evidence of whether cannabis or any medical intervention works. And that will be a precursor to our next foundation session, which is tomorrow, led by Dr. Bussa, who will be giving a deep dive into what we know about the evidence for medical cannabis for a variety of different conditions. But the important thing is really to start with a framework within which we can evaluate cannabis and evaluate it just like any other drug. Treat it with no greater bias or favor than any other medical intervention. So let's start with cannabis fundamentals. And what I want to start with is a very simple question. What are cannabinoids? And fundamentally, what we're talking about are a variety of different products and compounds that act on the endocannabinoid system. And let's start with this as the first category of things to understand, endocannabinoids. And then plant-based products we'll talk about next, medicinal plant cannabis, recreational plant cannabis. We'll talk about pharmaceutical cannabinoids, and then finally, synthetic cannabinoids. So as you can tell from the start, this is a complex landscape. There are a lot of different products out there. And actually, to simplify things somewhat, one thing we can do is consolidate the plant cannabis products together, because fundamentally, although a lot of people make distinctions between medical cannabis products and recreational cannabis products, what we're talking about are all varieties of different plant products that sometimes are used for medical purposes, sometimes are used for recreational purposes, and there are a lot of blurred lines. So really what we're talking about are 4 different categories of products here. And really, to start with, we're not talking about a product when it comes to endocannabinoids. We're talking about the body's own internal cannabinoid signaling system. And what I mean by this is the endocannabinoid system refers to a lipid signaling system within the brain that essentially facilitates communication in a wide variety of different regions using primarily what's called the CB1 receptor, or in a lesser extent of cases, the CB2 receptor, the cannabinoid 1 and the cannabinoid 2 receptor, and using 2 different molecules in the brain. The first is arachidonyl ethylenamide, or what is typically called anandamide. The second is 2-arachidinyl glycerol, or 2-AG. Anandamide and 2-AG are the principal endocannabinoids, and these are molecules in the brain that are critical parts of our healthy day-to-day neurotransmission and neural communication. And what you can see here is a PET scan of the distribution of the CB1 receptor in the brain, and basically where you see heat, where you see the red localization, that's where the greatest distribution, the greatest density of CB1 receptors are located. And what you can probably see is that, number one, they're located all over the brain. In fact, the CB1 receptor is the most abundant G protein coupled receptor. After the 2 big ionotropic receptors, GABA and glutamate, CB1 is actually the most abundant other receptor. And it's proliferated all over the brain, but specifically localized in regions of the frontal lobes, as you can see to the far right, where you see the red in the frontal lobes. It's also highly dense in the rear of the brain, in the occipital lobes, which is why cannabis often affects visual perception. You can also see that it is very densely populated in areas of the midbrain, and the basal ganglia in the amygdala. And fundamentally, the CB1 receptor is critical for neural communication and brain activity in general in these regions essential for different aspects of cognition and emotion, whether it be the prefrontal cortex, the amygdala, the hippocampus. The endocannabinoid system is implicated and critical for the day-to-day function of these systems. This is just part of our normal, healthy physiology. So now let's move on to plant cannabis products. And when we're talking about plant cannabis, we're talking about three species in the genus cannabis: sativa, indica, and ruderalis. We don't hear much about ruderalis because it doesn't have high levels of the cannabinoids that are of greatest interest, like THC and CBD. The lore is that cannabis sativa plants produce products that tend to be more stimulating, more activating. Cannabis indica plants with thicker, wider, stubbier leaves produce more sedating psychoactive effects. There's actually no scientific evidence in support of that differentiation by species, although it's certainly the case that there are many different strains of cannabis. The distinction between sativa and indica is largely mythology rather than science. And the reality is that there has been so much cross-fertilization and cross-breeding that a lot of the plants that are either labeled as sativa or indica in the market, if analyzed genetically, would be found to be hybrids to a certain extent. So certainly there are different kinds of plant products. There are different geni, but the difference in psychoactive effects is largely mythology. The reality, though, is that plant cannabis products are extremely complex. And a way to understand this complexity is thinking about it through the lens of how we traditionally think about different pharmacological products. Namely, that we think about how a molecule affects the body and brain, its pharmacodynamics, as well as how it is consumed and passes through the body, its pharmacokinetics. And these two factors really are responsible for the acute and chronic effects of any given drug. And to illustrate how cannabis is complex, let's start with another psychoactive drug, for example, cocaine. You can see there the molecule for cocaine hydrochloride. Cocaine can be taken via a number of different routes of administration, and it has potent acute and chronic effects on the body. But fundamentally, what we're talking about is one molecule that in most cases is considered a high-risk molecule, although it does have some therapeutic applications also. Another example of a relatively straightforward molecule is nicotine. There's the nicotine molecule. Nicotine can be consumed via, again, a variety of routes of different administration. It has acute and chronic effects. What's interesting about nicotine is that when it's consumed via inhalation, particularly through combustible tobacco, it has a relatively high abuse liability. And unfortunately, people can develop tobacco use disorder. But in its other formulations, like transdermal use via the nicotine patch, it actually can serve as a therapeutic. So the same molecule via different routes of administration can actually have quite different roles. When it comes to cannabis, it is much more complicated because within the cannabis plant, there are more than 100 different cannabinoids or molecules that have biological activity on the endocannabinoid system. So we're not talking about a single molecule. We're talking about basically a bucket of molecules. And the one that you're probably most familiar with is THC. You can see the molecular formula for THC there. There's also CBD, but then the list goes on. Cannabichromene, cannabigerol, cannabinol. And when we think about the cannabis plant, it really is so much more than just THC and CBD. As I said, cannabinol, cannabigerol, cannabichromene, but then we have all the volatile oils also, the terpenes, compounds like myrcene, limonene, alpha-pinene, humulene. Each of these also can have activity in the endocannabinoid system. And so this is a plant that is incredibly rich with different biologically active constituents. It has more than 100 different cannabinoids that actively act on the endocannabinoid system. The other thing that is important to know is that over time, the strength of the products that are available has been gradually increasing. So this is data that goes from confiscated cannabis going back to the mid-1990s, showing that gradually over time, the strength of cannabis has been getting stronger and stronger, going from about 4% in 1995 up to over 12% in 2014. And this has continued in contraband markets, but if you look at the legal markets, the products that are available now tend to be much stronger than the products that have been historically available. When I think about this, I often use the metaphor for alcohol because 4% is around the same strength as beer when it comes to alcohol, and 12% or as high as 15 or 16% would be like strong wine. And what we now see is that most of the recreational products are around 14, 16, 18, sometimes greater than 20% THC, indicating just how strong the contemporary products are. So in addition to there being many different products within the cannabis plant, in general, the products that are available are much stronger than they used to be. There are also many different kinds of products. So for example, now there are what are called extractions or concentrates, which, to keep with the alcohol metaphor, are somewhat like grain alcohol to the extent that these are products that can have THC levels up to 90%. Basically, these are products that are created by dissolving the plant matter in solvents like butane, for example, and then extracting the residual products in very highly concentrated forms. That's why they're called concentrates. They're often named according to the way they look after the process is over, with very evocative names like butter, shatter, wax, crumble, gelato. Fundamentally, these are products that are quite different from those that have been around historically, and they are at vastly greater strength than the products that have been around previously. The other major change is that there are now many more edible and drinkable products in the market, and indeed, the array of different routes of administration has dramatically increased. Of course, there are food products, now there are drink products. Cannabis suppositories have been considered perhaps the next frontier for cannabis products. Really, in addition to the variability in compounds, the variability in routes of administration has increased dramatically also. So let's move now to the pharmaceutical cannabinoids. So those are fundamentally, the plant cannabis products are all products that come from the plant in some way and act on the endocannabinoid system. Pharmaceutical cannabinoids, in contrast, are medical products that are not necessarily from the plant and have gone through the usual process of being vetted in terms of medication development. And they include 4 different approved medications. The 2 top ones you can see, nabilone and dronabinol, are synthetic formulations of THC. They are taken orally, typically in capsule form or as an oral solution in some cases. And they have been approved for treating nausea and vomiting in chemotherapy. They've been approved for increasing appetite in the context of treating individuals with AIDS. In the case of dronabinol, there is some use for chronic pain also. So unlike the plant products for which typically no prescription is needed, typically either an authorization in Canada or some sort of a medical permission is needed in other jurisdictions, these are traditional pharmaceutical products that have been produced that are inspired essentially by the plant products. The other two that certainly bear mentioning are nabiximols and cannabidiol. Nabiximols is a combination product that includes both THC and CBD. It's delivered, its route of administration is through a spray into the oral mucosal space, basically directly into the mouth. It is intended to balance both THC and CBD effects by having an approximately 50-50 distribution of both. And it has been approved for neuropathic pain and for treating spasticity in multiple sclerosis. Cannabidiol is the most recently approved medication and is a plant-based medication or a plant-based, highly purified CBD formulation. Its route of administration is via an oral solution, and it has been approved for essentially refractory pediatric seizure disorders only at this point. Conditions like Lennox-Gastaut syndrome and Dravet syndrome, which tend to be very severe, debilitating seizure disorders that are unfortunately often not responsive to traditional anticonvulsant medications. So there are traditional pharmaceutical versions of plant products, but they represent a quite different category from the plant-based products themselves. The way I like to frame this is in some ways sort of like the progression elsewhere in medicine where products from plants have ultimately become traditional medicine. So, for example, the bark of the willow tree contains a product called salicin, which was a medieval remedy for treating pain. It was determined to be a powerful analgesic and was consumed basically as shaved versions of the willow bark, and that has subsequently been converted into salicylic acid and then acetyl salicylic acid, which is the active ingredient in aspirin. So a product that is found in nature and was discovered hundreds of years ago to have anti-inflammatory and analgesic properties now exists in our traditional medical landscape and is inspired by the plant, but is not actually the plant anymore. That's really a way to understand the difference between the pharmaceutical cannabinoids and the plant cannabinoids. One of the big questions is, why are the non-pharmaceutical products so much more commonly used when it comes to medical cannabis? And this is something that we'll discuss over the course of the meeting, but this is a substantial open question. One of the issues with the pharmaceutical products is in some cases they are pharmacologically somewhat different. Dronabinol and Nabilone are synthetic products that mimic THC but are not identical to THC. The other issue is these products are taken typically as oral medicines. Most typical medicines are not inhaled the way cannabis typically is consumed. So it may be that the route of administration means that the onset and the offset of the effects are less potent, and that's why they are perceived to be less effective than the non-pharmaceutical products. Another hypothesis is that the plant-based products may have not only THC and or CBD, but they have a variety of different cannabinoids, as I alluded to, and that this variety has what's called an entourage effect, that altogether these different plant cannabinoids have a collectively larger impact on the endocannabinoid system. And as a result, they provide better benefits that the pharmaceutical products cannot. And then the last possibility is that the non-pharmaceutical products may simply lend themselves to stronger placebo effects or expectancies, because in many ways, the consumption of the non-pharmaceutical products involves a lot of the features that lead to strong placebo effects: ritual, different paraphernalia, a strong evocative sensory experience, and a direct experiential effect also. Whether or not it's a combination of these is not clear, but certainly the non-pharmaceutical products are much more widely used than the pharmaceutical products in terms of medical cannabis. Let's move on to the last category of products that are called synthetic cannabinoids. And in this case, what we're talking about are entirely novel synthetic molecules that have been developed in laboratories and discovered to act on the endocannabinoid system. So plant-based products occur in nature and act on the endocannabinoid system. Pharmaceutical medicines are inspired by those plant products. These synthetic cannabinoids are entirely new. They do not exist in nature, nor do they try to imitate the phytocannabinoid products. And they have, as you can see, extremely baroque and unintelligible names. They are fundamentally not like endogenous or plant cannabinoids, and they are sprayed on plant material to resemble cannabis and then sold ostensibly for as air fresheners, as potpourri, but then can be consumed. But essentially, they're poisons, unfortunately. They have very powerful effects and can often disrupt body temperature, can induce delirium. There have been, unfortunately, instances of widespread poisonings in both Canada and in the United States. And so these represent a high-risk category that's unlike the other categories and is essentially a use of chemicals discovered to act on our natural endocannabinoid system in essentially as mind-altering substances. Okay, so these are the four big categories. Let's move on now to a brief history of cannabis as it is understood in and used in Canada. And here's a timeline to give you a sense for a lot of the dramatic changes that have happened over the last few years and 2 decades. So prior to 1925, cannabis was legal, but it became technically illegal based on the Geneva International Convention on Narcotics Control. And then for most of the 20th century, it was illegal, whether for recreational or for medical purposes. But medical cannabis became legalized in 2001 under a set of regulations called the MMAR. And those regulations were then refined substantially in 2014 and 2017 because of challenges patients reported in terms of accessing medical cannabis. And I think that the important thing to be aware of is that this took place by way of the courts, not by way of the traditional pathways of approving medications. So individuals petitioned for access to cannabis for compassionate purposes and because they found benefit. And this was held up by the court system rather than through the traditional medical approval system. The access to cannabis originally was via Health Canada and was considered highly inefficient and did not provide access to the products that patients wanted. And so the MMPR and then the ACMPR were regulations that created the contemporary system of licensed producers who sell directly to patients a wide variety of products and reflect the contemporary medical cannabis landscape. Obviously, this changed substantially further when recreational cannabis was legalized on October 17th, 2018. And then a year later, legalization of edible products also took place. So the landscape has continued to change dramatically. What's really notable is that over this time, there has been a very dramatic expansion of the number of individuals who are using medical cannabis in Canada. So even though cannabis became legal for medical purposes in 2001, a comparatively small number of people were actually availing themselves of the legal system. But with the passage of the MMPR and the creation of the licensed producer system, many more people started to access that market. And so the expansion has been very dramatic, as you can see just by the overall curve. If we zoom in here, those are medical authorizations from Health Canada. If we zoom in, you can see that in 2014, there were fewer than 8,000 registered medical cannabis users. And that number shot up to more than 340,000 right before legalization, or right around when legalization took effect. That's a more than 4,000% increase. And that number has actually been remarkably stable. Many people thought it would reduce dramatically with legalization, but you can see since legalization, this again is the total number of active medical cannabis authorizations from Health Canada, that it has stayed quite stable at around 350,000. You can see there's a very notable decrease during the initial lockdowns during the COVID-19 pandemic, but actually it has rebounded substantially. And again, hovers over 300,000, typically over 350,000. So that's a lot of people who are actively using medical cannabis. And actually, we think that this is a pretty dramatic underestimate, just because many people who report using medical cannabis are not getting an authorization from a physician. Just to give you an example of this from some of our own data, we conducted a study looking at community adults and asking them about their health behaviors in a variety of different areas. And in our health registry, of the 709 people who reported cannabis use, a substantial proportion, nearly 40%, reported some kind of medical use. 31% reported that they used cannabis both for recreational purposes and for medical purposes, and 7% reported medical purposes only. So what we saw actually was that in this cohort, about 80% of the people who were using cannabis for medical purposes said they were also using it for recreational purposes. And only a small minority, about 20%, were using it for medical purposes only. Equally important, what we saw was that a small minority were working with a physician in terms of their medical cannabis use. Only 23% had a physician authorization, so about 1 in 4, suggesting that the rate of actual medical cannabis use is much higher. And of course, as you'd expect, this rate was higher among the people who were only using cannabis for medical purposes by their own report. But even there, fewer than half had a physician authorization. So these authorizations almost certainly undercount by a very large degree. I think if you do the back of the envelope math, it suggests that probably more than 1 million people are actively using cannabis for medical purposes at this point in Canada. So there's been a huge expansion of the number of people who are using cannabis for medical purposes. How do we put this in context with the broader epidemiology of how much use is happening in general? Well, let's look at some recent trends in terms of Canada's cannabis use in general. So if we look at past year use, and this is looking at Canada and also a number of comparator nations, you can see that around 14% report any use among individuals 15 to 64. That's a bit lower than the US, which is over 16%. It's higher than a number of comparator nations within the Commonwealth or other first world Western countries like Germany or Sweden, which have rates that tend to be between 3 and 10%. So on balance, the rates tend to be higher in Canada than elsewhere, although not as high as the US. If we look at cannabis use disorder, the rates are non-trivial, but relatively low. So there's a lifetime prevalence of cannabis use disorder in Canada of approximately 7%. That's over the entire lifespan. At any given time, it's estimated that about 1.3% of the population meets criteria for cannabis use disorder. So a small minority of individuals who use cannabis, but nonetheless a rate that is non-trivial by any standards. If we look at it in context in relation to other drugs, here you can see the population subdivided into different age groups, and you can see the most common psychoactive drugs used in order from 1, 2, 3, 4, 5. We're not including tobacco here. You can see that the most commonly used psychoactive drug in general remains alcohol in the general population, and also as you subdivide by different age groups also. But cannabis is behind that in every case. So in general, again, about 14.8% of the general population report any cannabis use in the past year. That number goes up within adolescents to around 1 in 5, 19%, and goes to about 1 in 3 among emerging adults or young adults, individuals in their early 20s. For individuals 25 and older, that rate is a bit lower, down to around 13%. So cannabis use is common. It's not as common as alcohol, but after alcohol, it's the next most commonly used psychoactive drug, and it is head and shoulders above all of the other psychoactive drugs, as you can see in terms of rates of cocaine, hallucinogens, prescription drugs, and other psychoactive drugs. If we look at changes over time, you can see that prior to legalization, there were a number of interesting trends. The rates were escalating for 2 groups in particular, older adults, 65 and older, and also young adults in their early 20s. Interestingly, adolescents were actually going down prior to legalization, and there were general trends that reflected the aggregation of these different lines, generally reflecting a gradual increase in patterns of use. If we zero into what's been happening since legalization, what we can see is that the lines are not dramatically fluctuating. There was a notable spike in the second quarter of 2018, which actually precedes legalization. But in general, the rates have not been dramatically going up across the different age groups. The biggest differences are between the age groups, not so much over time. What we do know is that there are very big sex differences when it comes to cannabis use. Males use cannabis at a much higher rate than females. And what's interesting is that the rate of increase seems to be somewhat higher in males also. From 2013 to 2017, their rate went from 14 to 18%, whereas females went from under 8% to about 11%. But the biggest difference here is more between males and females than over time. And then if we look at sex differences over the course of following legalization, we do see that it appears that there have been slightly larger increases in cannabis use among males since legalization compared to females who exhibit a slightly flatter line. What's interesting is that depending on the cohort, you do see different patterns. So for example, we conducted a study examining a number of community adults and examining their patterns of cannabis use over the course of legalization. And what we found was that although there were significant changes over time, in this cohort of individuals that we were able to follow at multiple time points, we found that actually the individuals who were using cannabis prior to legalization actually showed slight decreases over the 6-month follow-ups following legalization, and individuals who were not using cannabis prior to legalization showed slight increases, reflecting some individuals who were not users, not never users, but not users, resumed some level of light use. This is the pattern of changes in terms of how frequently they were using cannabis. If you look at the misuse severity on a measure called the QDIT, the Cannabis Use Disorder Identification Test, you can see the same pattern of results, slight decreases among people who were using prior to legalization, slight increases among individuals who were not using prior to legalization. And then finally, in terms of the amount of cannabis that was being used, we see the same pattern. So it's not as simple as increases or decreases. It seems to be very much a matter of different subgroups changing patterns of behavior in different ways over time. And obviously, as we approach the 5th anniversary of legalization next year, we'll be doing a lot of intensive examination of how we understand these very multifarious patterns of change over time. Okay, The next focus is really on the reality that the impacts of cannabis, both good and bad, are almost certainly not likely to fall equally across the population. So it's really critical to understand the impacts of cannabis within important population subgroups. And we've really identified 4 groups of individuals who are differentially likely to experience benefits or risks. With regard to the first, adolescents and emerging adults, as I showed before, the rates of use are highest among youth. Whether you look at teenagers or emerging adults in the early 20s, that's the group that's using the most cannabis. And so the potential for potential risks is highest among adolescents and emerging adults. Another reality, unfortunately, is that individuals with psychiatric disorders tend to use cannabis at higher rates and often can observe or experience exacerbations of psychiatric illness during cannabis use. We'll talk about that in great detail on Saturday morning in the context of the Potential Risks and Harms Foundation session. But both of these groups represent individuals who are at differential risk. We'll dive a little bit more deeply into veterans and seniors because there are some important nuances there. So why focus on veteran health in the context of cannabis? Well, the reality is there are significant occupational risks of military service, and those risks are known to relate to the development of pain. Estimates in Canadian veterans suggest that about 4 in 10 report chronic pain, and another quarter report some degree of intermittent pain, often by dint of their military service. The other reality is, unfortunately, that military service can lead to mental health conditions, including post-traumatic stress disorder. And these are some of the most common conditions, pain and psychiatric disorders, that lead people to investigate medical cannabis. And the other unfortunate reality is that there is a substantially higher risk of suicide among veterans. And there are implications of cannabis with suicidality. So there could be both possible benefit for pain and for certain psychiatric conditions, but also the possibility of exacerbations in an already vulnerable group. The other reason that it's important to understand benefits and harms for veterans is because the veteran population has differential access to medical cannabis. Veterans Affairs Canada reimburses medical cannabis and is one of the few insurance programs in Canada that does so. And as a result, veterans are able to access medical cannabis and do so at increasingly large amounts, or I should say increasingly high rates. So these are the data showing the reimbursements and the grams reimbursed over the fiscal years from 2011 to 2019, 2020. And you can see that over time, there has been a dramatic increase in the number of veteran clients who have sought medical cannabis and been reimbursed by Veterans Affairs Canada, most recently adding up to nearly 15 million grams of cannabis reimbursed at a cost of nearly $120 million. So there's a lot of cannabis being consumed, and it's really critical to understand whether this is a beneficial product for the conditions that are it's being used for, or whether there are significant risks that we should be aware of given this access and level of consumption. What we know, unfortunately, is that US data suggests that there can be differential risk among veterans. So these are data from a study looking at US, Iraq, Afghanistan era veterans and looking at individuals with cannabis use disorder and whether or not they had a history of a lifetime suicide attempt or were reporting current suicidal ideation. And what you can see in this relatively large sample of more than 3,000 veterans is that the rates of suicidal ideation and lifetime suicide attempt were much higher among those who had cannabis use disorder, more than double in both cases. In another similar study, This is actually looking at a different subset of veterans, again, from the US, in Iraq, Afghanistan era veterans, now looking at self-injury, whether it be any self-injury, suicidal self-injury, or non-suicidal self-injury. Cannabis use disorder was, again, associated with a much higher rate of these self-harm behaviors. And as a result, it seems like there really is particular need to be aware of the risks associated with cannabis use, and particularly the presence of cannabis use disorder in veteran populations. What about seniors? Well, when it comes to seniors, what we know is that unfortunately, many seniors struggle with chronic medical health conditions and are interested in identifying new treatments that might either provide better management or might reduce their need for use of other medications and reduce the number of medications they might need. There's also a belief that's been reported that because it's a plant product, cannabis might be natural and therefore less harmful than other pharmaceuticals. We've seen reports that seniors often find that they get advice from family members to consider trying cannabis. And the other reason to be particularly interested in seniors is because, unfortunately, seniors have unique risks and vulnerabilities. For example, cannabis, at least with some degree, some amount of THC, is associated with motor impairment and can lead to higher risk for falls or other mobility issues. Cannabis effects on cognition could either have consequences for cognition in general or could suggest declining cognition when in fact it is a consequence of cannabis effects. And then the other reality is that cannabis can have, and constituents of cannabis can have drug interactions. And because many seniors are often taking multiple medications, it's not always clear whether or not cannabis is interacting with those drugs and could have adverse consequences as a result. The other reason is that there has been a dramatic increase in cannabis use in older populations. In US surveys, there's been reported a 250% increase from 2006 to 2013. Health Canada has also reported similar notable increases. These are data you can see from Q1 of 2018 to Q3 of 2019. And what you can see is over time, a pretty dramatic increase from a percent of 4% to 7.6% by that last quarter, again, suggesting that many seniors are trying cannabis in the current climate in Canada. Okay, last consideration as we prepare for the rest of the meeting is how to think about evidence of benefits and harms. And what we're often going to talk about over the course of the conference is, again, both sides of the coin. How do we ascertain how much benefit there is, how much therapeutic efficacy there is? How do we ascertain the potential risks and harms? And how do we balance the two to best understand whether or not we would want to recommend medical cannabis for a variety of different conditions? And in this case, often what we're going to discuss is what's called the grade system, or grading of recommendations, assessment, development, and evaluations. This is a framework for essentially evaluating the evidence base for any medical intervention. And it's a way of systematically characterizing the quality of evidence in one direction or the other for an intervention. And what we're going to try to do is take not just any single study, even if it's really well conducted, and use that as the basis for a recommendation, but look at the totality of evidence, often using systematic reviews and meta-analyses, and converting the results across the literature into important indicators that tell us about benefits and harms. Just to give you two examples, we're going to talk about an indicator called the number needed to treat, which is the number of patients that need to get a medical intervention in order for one person to experience a meaningful benefit, and the number needed to harm, sorry, there's a typo there. That should be NNT and NNH. And the number needed to harm is the number of patients who need to get a medication to experience a meaningful side effect or downside from the medication. And these are indicators that we use in order to quantify the pros and the cons, and then make recommendations based on the balance of the evidence, bringing together both pros and cons, and of course, patient preferences. So using this framework over the course of the conference, we're really going to try to, again, think not about whether we are pro-cannabis or anti-cannabis, but whether or not the benefits outweigh the harms when it comes to the totality of the evidence. The other thing that we're going to do when it comes to the potential risks of cannabis is really focus a lot on dose-response relationships. That is, how much cannabis is associated with significant risks and harms versus how much cannabis is associated with essentially minimal or no harms. And unlike unlike alcohol in particular, where there are guidelines for quote unquote healthy drinking levels, in this case, we don't have low risk cannabis guidelines. We do have lower risk cannabis guidelines. And we're going to focus on how do we parse the data to understand where that risk lies and where it lies in a variety of different domains, psychiatric domains, cognition domains, lung health, and a number of other areas also. So just to recap, as we go forward, there are many different molecules and products that are out there when it comes to cannabis and cannabinoids. They can broadly be divided into those four categories: the compounds that exist naturally in our brains, those that come from plants, those that are inspired by plants, and those that come from exclusively labs. There is a very high rate of cannabis use in general. It tends to be among young people and especially males. The patterns of change are clear, although they're complex and do not appear to be dramatic increases or decreases, so much as more modest changes and with substantial differences either by cannabis use status or sex. And then finally, if we follow the evidence, we rarely get to a black and white recommendation. What we need to do is think critically about benefits and harms when it comes to cannabis and make recommendations based not on a single study or an anecdote, but the totality of evidence that exists, both in terms of benefits and in terms of harms. And I'm going to stop there. Welcome again to our conference. I look forward to the formal kickoff tomorrow, and also to answering any questions that might have come up over the course of the talk. Thank you.
Thank you very much, James. That was a great talk to start off the conference. So once again, if you have any questions, please use the Q&A function. I'll read off the questions and then perhaps James can answer them. From Asel Albiate, do you think that having a cannabis use disorder and having higher suicide ideation in veterans has anything to do with impulsivity?
I would certainly imagine that it does. What we know is that cannabis use disorder is associated with a variety of different forms of impulsivity, and that includes overvaluation of small immediate rewards relative to larger delayed rewards. It includes associations with negative and positive urgency, or acting out when you're experiencing negative mood states or positive mood states. And unfortunately, I suspect that those self-regulatory processes may very well be implicated in self-harm and suicidality also.
Another question from Tom Bell. I was surprised to see few or no CB1 receptors in the cerebellum on the images shown at the beginning of the presentation. Are there not numerous receptors in the cerebellum as well?
That is a great question. And I think that the baseline green there does indicate that there are CB1 receptors in the cerebellum, but they are not as dense as elsewhere. And that is in part perhaps why cannabis, while impairing of motor, is not as impairing, for example, as alcohol, where you have very dramatic impacts on cerebellar function. And that's why you have gait disturbance, weaving, eye movement problems, and kind of frank difficulties, whereas the effects on motor performance tend to be somewhat more subtle when it comes to cannabis. And so the short answer is there are CB1 receptors in the cerebellum, but it is not a very, very richly expressed receptor there. And that may be partially why the effects are somewhat more subtle when it comes to motor impairment, for example.
From Haley Bernowski, did you mention where the grade system comes from? Is it your own method?
That's a great question. So it is not my own method, but it was developed in part here at McMaster University. It has been adopted and developed and refined elsewhere. It will be discussed explicitly, or I should say at greater length, by Dr. Bussa tomorrow. But it is one of the accepted frameworks for evaluating evidence. It was originated here at McMaster, but has then really expanded to an international footprint.
From Julia Barrows, do we know why synthetic cannabinoids are so toxic / dangerous?
That's a great question. I don't think that we know that very definitively. What we know is that their binding potency is extremely high, and the cannabinoids that we are quote unquote used to consuming are not the same as the endocannabinoid molecules in our brain. It's not like THC is an external version of anandamide. They happen to act on that system, and they're not as efficient as the internal endogenous cannabinoids. The synthetic cannabinoids are unbelievably potent in terms of their binding to the endocannabinoid CB1 receptor. And it's believed that it's those kinds of sort of, binding on steroids relationships that lead to the much more dramatic and pronounced effects. The other reason that it's believed that the effects may be particularly problematical is because they are manufactured illicitly and essentially sold as a contraband product. These are just chemicals that are sprayed on plant matter. There's none of the quality control or regulation that would go into producing a product. So you could, for example, inadvertently overconsume if the batch that you bought happened to have much more of the product than another batch. These are not manufactured according to any kind of standards that you would expect for either a food product or a drug product. So it may just be a matter of overconsumption by virtue of those kinds of contraband market issues.
And there's a final comment from Leah in the chat, who suggests that research going forward needs to clarify which molecules, not just cannabis.
That's exactly right. I think that, my interpretation is that Leah is correctly picking up on the fact that when you say cannabis, what you mean is a category of products, not a specific molecule or indeed set of molecules in a certain product. So it is really a category or a rubric more than the simplistic way that it's often discussed.
And there's one more question that just came from Marshall Lopez. U.S. national data in youth has shown a closing of the gap over time between males and females. So the difference in prevalence of cannabis use is pretty much non-existent now and is the same for boys and girls. Are you seeing any variations in male-female differences by age group in the data you presented or in more recent years?
That's a great question. I believe that that's the case. I think that the gap has persisted primarily in Canada. We haven't looked recently at the national data or within our own cohorts, but I think that this is an area where there may be a substantive difference between the two countries, because my understanding is that the male-female sex difference remains pretty robust here in Canada.
And I think that's all of the questions for this session.
Wonderful. Well, thank you everybody for participating. It's great to have you join our conference. I'm looking forward to the rest of the next 2 days. Bye-bye.